Hi dear students, today we will discuss a very important topic which is chemical control of breathing. How breathing is chemically controlled and why it should be controlled chemically. What's the effect of CO2 and O2 or what's the effect of the CO2 on the pH and what's the effect of pH on breathing and what's the effect of breathing on pH? Why they are so related? And what's the effect or the relation of hyperventilation increasing the rate and depth of breathing? This is the hyperventilation that the patient have, and this will affect and cause several symptoms to the patient. And as we see in the panic attack, when sometimes due to psychological problems, sometimes due to emotionally affect this hyperventilation, it's not in the hand of a patient. And what will happen? There will be increased oxygen, but decreasing the carbon dioxide by removal of most carbon dioxide from the lung. And so the patient complaining of several symptoms like lightheadedness, dizziness, fainting, or nausea, abdominal or chest pain, and tingling sensation around mouth and in the hands also, in the limbs. There's also sometimes abnormal breathing, other abnormal irregular breathing, and mostly these hyperventilations by attacks. There are attacks of hyperventilation, and also there are other causes, tiredness, high altitude, or panic attack, as we said, and caused by the drug and other. That's why we have to exclude other causes of hyperventilation before treating the patient. And the most important treatment for these patients who have chronic hyperventilation is breathing, the sort of breathing. They have to breathe out deeply and breathe in also deeply. This is important. And also you can, in the emergency situation, we can give a bag, a paper bag. This may help the patient. Rebreathing into a paper bag, breathe in and out in a paper bag. Why this could help the patient? Breathing into a paper and breathing air on expiratory air. Why this is important for this patient? Thus, the learning outcome of today's lecture is to know what is hypoxia, hypocapnia, and what hyperventilation and hypoventilation, and what are the effects of this hyperventilation on the changing plasma pH. And what is respiratory acidosis, respiratory alkalosis, and what are their compensation? And what are metabolic acidosis and alkalosis and their compensation? And what's the effect of falling PO2 and increasing PCO2 and changing plasma pH on the ventilation? And also important to describe what's the peripheral chemoreceptor and what are the central chemoreceptor and what are their sites, their location and their function of these receptors and their role in the body. Of course, when we say there is control of ventilation and the ventilation is under control, it is not only under chemical control. Chemical control is very important, of course, but it is not the only control. Ventilation is also under other control. Well, there is the respiratory center, of course, in the medulla oblongata. This is the respiratory center, and it will receive drive from several area of the body and from the several stimulus. One of them is chemical control, but others are. One of them is emotional stimuli, the one that discussed previously. Emotional pain, panic attack all affect the respiratory center and increase in the ventilation. This is mostly, for example, due to stressful situation and need more O2 to the body. And also, in the respiratory center under control of the higher cortex, cerebral cortex, higher centers, higher brain center, and also stretch receptor in the lung when the lung become increased in the stretch, and also irritant receptor in the bronchial and the lungs, the alveoli, and also even by the receptors from the muscle and bone. Do you think that the muscle and bone have receptor and send signal to the respiratory center for controlling breathing? What do you think? When this one is important and activate and put signal to the respiratory center? Of course, during exercise. Why? During exercise, sometimes even at the very start of this exercise, even before changing the chemical composition of the blood of these chemicals that affect the chemoreceptors of the body, before changing these, there will be increasing the hyperventilation. Why? What's the stimulation? The stimulation is movement due to the muscle contraction and the movement in the joint, which are called proprioceptors. They send signal to the higher center. So these are all control of ventilation, but the most important control that we will discuss today is chemical control of ventilation. Of course, the um, oxygen usage and production of CO2 will be changed, and it's under change from moment to moment. So we should have a precise mechanism in order to maintain normal O2 and CO2, or normal alveolar PO2 and PCO2. If the alveolar PO2 and PCO2 is normal, so the arterial and the blood PO2 and PCO2 will be also normal. We have an ABG. ABG's arterial is the abbreviation of arterial blood gas analysis. This is an investigation which is important, and we said this is the real lung function testing because it tells you about the gases in the blood. For example, tell you about the arterial CO2, concentration of arterial CO2, arterial PO2, the bicarbonate, the basis excess or the deficit, and also saturation of oxygen, and also it gives you the normal pH. These are the normal values of these parameters. For example, for the pH is 7.35 to 7.45 is regarded as normal. You could find some difference in these parameters in different references. Only slight difference is no matter, because normal range is mostly given whenever you have a result you want to find or to know if it's normal or not. PO2 and PCO2. You know, PO2 and PCO2 means concentration of oxygen and concentration of carbon dioxide. Which one do you think is most important here in the control of breathing? Of course, both of them is important, but I will ask you a question. What do you think? Which one of them need greater change for the body to respond, or for the respiratory center to respond, for the breathing to be controlled? PO2 or PCO2? PCO2 is mostly important. PO2 need greater change or decrease from normal in order for the sensor to sense it and to stimulate the body to control breathing and increase the ventilation. For example, the PO2s need 5.3 kilopascal change in order for the body to stimulate and cause hyperventilation, while PCO2 need only 0.3 kilopascal change, so the body can sense 0.3 kilopascal change and cause hyperventilation. So this is under more precise control, or we can say PO2 need greater change, or it is stimulation will happen lately. Why this like that? Of course, first we should look at the chemoreceptors. We have two types of chemoreceptors. We have the peripheral ones that are the peripheral are the peripheral one. These are the peripheral chemoreceptors where in the carotid bodies, here carotid bodies for the chemoreceptors, and this is the aortic bodies near the aortic arch, and this is near the bifurcation of the aorta, and these are the chemoreceptors. They sense the chemical change, chemical stimulation will affect them. And we have also central chemoreceptors. Central, of course, in the brain, in the medulla oblongata, the ventral surface of medulla oblongata. These two yellow bars are the central chemoreceptors that sense chemical change. So we have peripheral and central one. That's right. So we should have a sensors in order to know or stimulated by these the change or detect the change in these gases O2 and CO2 and H also. As we said, why PO2 associated should have a greater change in PO2 in order for the body to sense it, while all the body use oxygen. This is because of the if we look at this curve, which is HbO2 dissociation curve, we will understand why. Of course, from where we get oxygen, or the cells get oxygen from blood and from hemoglobin. So what is important in the blood? Although PO2 is also important, but the most important one is the percent saturation of hemoglobin. What's percent saturation of hemoglobin? Means the percentage of hemoglobin that bind to O2. Catalysachani hemoglobin kaman oxygen basrawa. This is important because hemoglobin give oxygen to the tissue and transfer oxygen to the tissue. If HB is 100% saturated with O2, so this is no problem, or 99 or 100% saturated with O2, so there is no problem to the cell, even if PO2 is low. Look at this graph. You know it's a sigmoidal shape. It's like that. Here, as you can see, here this one is the x-axis is PO2, concentration of oxygen. This is 13.3 kilopascal, means 100 millimeter mercury. This is the normal pressure of the PO2. Normal pressure. This is the normal one in the normal person. If it's PO2, or at this concentration of 13.3 kilopascal of oxygen, we have 100% saturation of hemoglobin. So 100% of hemoglobin were saturated with O2. What about lower PO2? At lower PO2? At lower PO2 also about 99 to 100% saturated. So there is no decrease or not great decrease in the saturation of hemoglobin until we reach to what? To 8 kilopascal. So when the oxygen PO2 become decrease, or there is a great decrease of 5 kilopascal, then the body is sensing it. Why? Because at this point the saturation of hemoglobin is dangerous, and it's begun to decrease, and it is also sensing it till 3.5 kilopascal. 3.5 is if it's below that, it's a very dangerous situation. So between 8 to 3.5 kilopascal will cause stimulation of the peripheral chemoreceptors and cause hyperventilation. There is another important point in this lecture I want to highlight. The central chemoreceptors, well, as we said, medulla oblongata, here we have the CSF. These are the chemoreceptors in the medulla oblongata. This is the CSF, cerebrospinal fluid, and this is the blood. And in the brain we have what? We have the blood-brain barrier. Okay. So the central chemoreceptors has only receptor for H ion. So they have receptor for H ion. While they cannot transport H, or they are a barrier, because it is blood-brain barrier. It is a barrier for H, and only CO2 can pass through them. So CO2 can pass through them, but it has no receptor for CO2. H cannot pass through it while it has receptor for H. And when we come to discuss the peripheral and central chemoreceptor, each of them are sensitive for one or two of the gases. For example, PO2 is only stimulate the peripheral chemoreceptor. pH or H change will only stimulate the peripheral chemoreceptor, while it has receptor here on the central chemoreceptor. Why? Another question. PCO2 affect both central and peripheral chemoreceptor, but it has no receptor in the central chemoreceptor. So how this could be stimulated? We'll take it later. So, oxygen hemoglobin dissociation curve indicate that the PO2 may vary over a wide range around the normal value of 13.3 kilopascal without any alteration in the degree of saturation of hemoglobin. So decrease of oxygen, of course, is called hypoxia. So when we say it's hypoxia, if it is less than 8 kilopascal, PO2 is less than 8 kilopascal, is called hypoxia. Before that, it's not called hypoxia because it doesn't affect the saturation of hemoglobin. Okay, what about carbon dioxide? The alveolar PCO2 has a very important role as CO2 form part of the principal system of controlling acid-base balance. So why CO2 is so much important? Why only slight change in CO2 should be detected? Because CO2 affect the acidity of the body or affect the acid-base balance. Decreasing or increasing CO2 affect the acid-base balance, and acid-base balance is important in order to prevent dysfunctioning of the organ and the cells and the body function. When there is a rise in alveolar and so the arterial PCO2, this condition is called hypercapnia. So you may hear hypercapnia a lot here. Hypercapnia means increase in the PCO2. Okay. What about hypocapnia? Hypocapnia means decrease alveolar and so arterial PCO2. This is hypocapnia. So hypocapnia means decreased PCO2, hypercapnia means increased PCO2. And these two terms are important as they affect the body and affect the pH. When we have change in PCO2, there will be change in pH of the arterial blood. How it will be changed? Change in PCO2 also important may be used to compensate for change in the pH. You will take it in the respiratory and the metabolic acid-base imbalance. So PCO2 therefore needs to be controlled to keep pH stable. Whenever you have high CO2 means you have high H ion. كتر CO2 زايد يعني acidity زايد كده H زايد كده, so we have decrease in the pH and vice versa for the decreasing in the PCO2. How the plasma pH is calculated, or how we can know what will happen to the plasma pH in case of change in the HCO3 and PCO2. We have an equation which is called Henderson-Hasselbalch equation. We do not use this long equation. I'll show you the shorter one that we will use it throughout the lecture. The pH of hydrogen carbonate divided by dissolved CO2 solution determined by this equation. We have a pH. We will calculate the pH by pH is equal to pK. pK is a dissociation constant plus logarithm of HCO3 concentration or bicarbonate concentration divided by PCO2 multiplied by 0.23. What is this 0.23? We need a dissolved CO2. In order to know how much CO2 dissolved, we have to know the concentration of CO2 in the blood multiplying by 0.23 because this is dissolved by this percentage. So by this, we get the dissolved CO2. So dissolved CO2 is therefore determined by the partial pressure of CO2 because 0.23 or the solubility of the CO2 is fixed. It's a fixed factor, so we do not use this. We can only say PCO2. So the pH of the plasma is determined by the ratio of HCO3 to PCO2. This ratio is very important and we will use that one. Note this. Don't worry about this equation. So pH is equal to concentration of HCO3 divided by PCO2. So whenever CO2 change, PCO2 change, or HCO3 change, there will be change in the pH. So we have three chemical stimuli to the respiratory center. One of them is increase in the CO2, PCO2, which cause what? Cause hyperventilation. Why when CO2 increase, there should be hyperventilation? The stimulus is hyperventilation in order to remove the excess CO2 and decrease or prevent acidosis. What are the receptors that sensing it? As we said, central chemoreceptors and peripheral chemoreceptors, both of them sensing the increase in the PCO2 or change in the PCO2. What are other chemical stimuli is decreased arterial PO2. Decreased arterial PO2 also causes hyperventilation, and this is by peripheral chemoreceptors that present the carotid and aortic body. So there's no action on central chemoreceptor. So when there's change in the PO2, it will not cause stimulation of the central, it only stimulates the peripheral one. What about pH? Chemical stimuli. pH is also among the chemical stimuli of the respiratory center, but it also affects the peripheral one, peripheral chemoreceptor. So decreased pH will stimulate ventilation. Why? Decreased pH means high H in order to remove more carbon dioxide and so decrease in the acidity. So the peripheral chemoreceptors are decrease in the PO2, pH, and increase PCO2, so sensing all these three. And PO2 range from 8 to 4 kilopascal, as we said, or 3.5 kilopascal, stimulate the peripheral chemoreceptors. Before 8 or higher than 8 will not stimulate it. And the response is increase in ventilation, while the response to arterial PCO2 is much less than the central one. So central CO2 sensor is more than or more sensitive than the peripheral CO2 sensor. There is increase in the chemoreceptor activity in response to decreased pH. So when there is decreased pH, the chemoreceptor activity increases. First, let's look at the response to oxygen. Receptors sensitive to falling PO2 are located in the peripheral chemoreceptor. And these bodies, carotid and aortic bodies, stimulated by decreasing oxygen because they have also oxygen supply. So when there's a decrease in the oxygen supply relative to their own oxygen usage, there will be stimulation of this receptor. Of course, the oxygen usage of them is small, not like the other organ. So when the oxygen greatly affected, they will sense it. There is a high rate of blood flow in these structures. This is important, so they do not normally change their response until the PO2 is low. So the PO2 should be or change greatly in order for these receptors to be stimulated, because they have normally their oxygen usage is low and also they have high blood flow. So when the PO2 decreases below 8 kilopascal, they become stimulated and sending signal to the brain center or respiratory center. Stimulation of chemoreceptor upon decrease in PO2. Stimulation of the receptor has a variety of effects. So when this receptor becomes stimulated, the peripheral chemoreceptor becomes stimulated by decrease in the PO2, As we said, there's hyperventilation, but also some other things happen. For example, apart from increase in the hyperventilation or tidal volume and respiratory rate, there's also change in circulation. They direct blood, more blood to brain and kidney. And also there is increase in the pumping of blood by the heart. All these are important to ensure good oxygen to the tissues. So they have a slight tonic activity and only respond to large fall in PO2. So their tonic activity is slight, not very rapid, and they need a great change, as we said. But this is important, they do not adapt. What does it mean by they do not adapt? We will see that the CO2 chemoreceptors are adapt. The central one, the central chemoreceptor for CO2 is adapt to the CO2, to that CO2. But this is not adapt. There is a respiratory drive as long as PO2 is low. So even if the PO2 is low for prolonged period of time, there is respiratory drive. There is effect on the respiratory center to control breathing. Let us see response to carbon dioxide. Chemoreceptor sensitive to rest PCO2 located in both peripheral and central chemoreceptor. In the peripheral chemoreceptor, they are not particularly sensitive to CO2 and needing a rise of 1.3 kilopascal in order to stimulate them. So, أبي CO2 1.6 kilopascal بقرأ, while the body can respond for CO2 change of only 0.3 kilopascal. كهذا body ب 0.3 kilopascal stimulate هنا كات control stimulate stimulate respiratory center كابتا hyperventilation. طبعا peripheral chemoreceptor بيسي ب 0.3 kilopascal هي. So what are the benefits of the peripheral chemoreceptor? They are of great importance only when there is a great change in the PCO2 because they do respond quickly. Their response is quicker than that of the central. So they are not crucial for the precise regulation of respiration, but do respond quickly to large change in PCO2. So when there's a condition that is associated with the great change in PCO2 or rapid instantaneous change in the PCO2, the peripheral chemoreceptor respond very quickly in order to adapt this change. But the precise control is by the central chemoreceptors. Central chemoreceptors, these are the central chemoreceptors are located on the ventral surface of medulla. As we said, they are exposed to cerebrospinal fluid. Exposed to cerebrospinal fluid. So the cerebrospinal fluid also, there will be diffusion of some materials and gases to it, and the composition of CSF is important. They respond to fall in the CSF pH. So when CSF pH or cerebrospinal fluid pH change, they will respond. And as we said, when the CO2 increase and the H change. And this is the question that we ask. As we said, only CO2 can pass through the blood-brain barrier to the CSF. And these receptors are only sensing H. And the central chemoreceptors are not sensitive to pH change, only to change in the CO2. How? Because H cannot pass through them, but CO2 can pass through. And as you know, by carbonic anhydrase and changing CO2 combination with H2O and forming HgCO3 and forming bicarbonate and H, when CO2 increases, there will be increase in the H production. So this H stimulates this one, the receptors. That's why whenever CO2 is high, these receptors become stimulated according to this mechanism. So they have sensor for H ion, not CO2. Hydrogen carbonate per bicarbonic acid buffer system. and it contains no hemoglobin. As you know, in most in the red blood cell we have carbonic anhydrase, but here there's no red blood cell, but we have this this change of CO2 to HCO3 and H. So the same equation. Choroid plaques cell pump HCO3 into and out of the CSF. Of course, in the CSF, we have the control of its HCO3 or its pH. The choroid plexus produce bicarbonate, has the ability to produce bicarbonate or HCO3, and it is independent of the plasma HCO3. But if there is a change in the PCO2, there could be change in the formation of the HCO3. So the pH of the CSF is mostly determined by its own hydrogen carbonate carbonic acid buffer system. It has a buffer system, a local buffer system. And dissolved CO2 in the CSF is determined by plasma PCO2. So whenever plasma PCO2 change, followed later by change in the CSF CO2, dissolved CO2. Also, it needs time, the rapid change in plasma PCO2 takes time to influence CSF, so it needs time, not quicker like that of the peripheral, as we said, but it is more sensitive. So just as in plasma, therefore CSF pH, and thus the stimulus to the central chemoreceptor determined by what? By the ratio that we discussed, ratio of HCO3 to dissolved CO2. So in the CSF, we also use this ratio. Whenever change, one of them change, will affect the pH of the CSF and will affect and stimulate the central chemoreceptor. So again, it is by this ratio we will calculate the pH of CSF. If arterial PCO2 change, after short delay, the CSF PCO2 will follow. What will happen? This will lead to change in CSF pH, which are sensed by central chemoreceptor, and normally cause change in breathing. And change in breathing or increase, for example, in ventilation, tend to restore the CSF pH towards normal. So this is important negative feedback mechanism that happen and cause control of ventilation. What will happen if this negative feedback doesn't work due to any condition, due to any disease or any other stimuli that present, for example, stimulus of oxygen, changing oxygen level that present, this negative feedback will not occur. What will happen? So if the CSF pH will not return to normal, what will happen? Let's see what will happen. There will be adaptation. How the central adaptation or the central chemoreceptor adaptation occur, adaptation to CO2 occur. If feedback doesn't occur because of an additional stimulus or because of a disease of the lung, there will be persistent change in the CSF pH. This persistent change in the CSF pH, so the abnormality remain, the abnormal pHs remain, this will stimulate the choroid plexus cells to pump more or less hydrogen carbonate into the CSF. So, as we said, the choroid plexus normally produce hydrogen carbonate or bicarbonate. If the pH is not corrected, for example, we have low pH, it will produce more HCO3. So change HCO3 production in order to maintain normal ratio HCO3 over dissolved CO2. So whenever there is change in the CO2, it will change HCO3 in order to maintain this ratio. Because in the acid-base balance, this ratio should be maintained for the pH to be normal or return to normal, HCO3 over dissolved CO2. So here, dissolved CO2 changed because of change in the PCO2. So the brain or the central chemoreceptor will change its own HCO3 in the same direction of the dissolved CO2 for the pH to remain at its normal level. By this, what will happen? it will do this locally in the CSF, but that of the blood will not return to normal because there is no, it will not affect the respiratory center or stimulate the respiratory center. And the CSF pH is corrected much more quickly than the blood pH because of its small volume, of course. So what will happen? By this will cause adaptation. The central chemoreceptor will adapt. How it will adapt? It will adapt to this and adapt to this high CO2 or low CO2 because it increase or decrease its SCO3. So it regarded as normal. It will reset the chemoreceptor into another value or the higher point. So when normally when it regard a level of PCO2 as high, but at this time it will regard this one as normal and it will reset to a higher point or the higher value. This will also reset to operate around a different PCO2. So this is the adaptation of the central chemoreceptor. As we said, the peripheral chemoreceptor do not adapt for change in O2, while that of the central will adapt. And here it is clear that in this curve, in this graphs, that the inspired PO2 is an insignificant influence upon respiration until it has fallen markedly. As you can see, there is when there is change in the PO2, this is the concentration of these gases. When there is change in the PO2, it will only cause stimulate respiratory or increase in the hyperventilation or increase in the respiratory rate and tidal volume when there's a great change happen. While in the CO2, it's much more sensitive and stimulated earlier.